Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with any commercial interest. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section. Also, a link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker, Dr. Adil Akhtar. Dr. Akhtar is a third-year internal medicine resident here at Northeast Georgia Health System. He brings a rich and diverse background in medicine, having studied and practiced across healthcare systems in Pakistan, Ireland, and the United States. His international experience has given him a unique perspective on healthcare equity, efficiency, and the application of evidence-based medicine. With a strong commitment to compassionate and high-quality patient care, Dr. Akhtar is preparing to graduate this June and will continue his journey in hospital medicine at Covenant Medical Center in Texas. Please join me in welcoming Dr. Akhtar.
Thank you, everyone. So my name is Adil. As Jennifer mentioned, I'm a third-year resident. And before I start the talk, I just want to thank Dr. Gross. He's the MVP of this talk because if it wasn't for him, this talk wouldn't be half of what it is right now. So thank you to Dr. Gross. So we'll be talking about colorectal cancer screening, the guidelines, trends, and ethnic variations. It's a month late because March was the month for colorectal cancer awareness, but it's in April, so later better than never. So let's start. So I have no conflict of interest to report. So what are we going to talk about during today's talk? Well, we'll talk about the epidemiology and pathophysiology of colorectal cancer. We'll talk about the updated screening guidelines, and we'll also talk about how do we screen for colorectal cancer and what are the applications of different modalities. And then we'll discuss the inpatient use of FOBT that we do a lot here in our hospital and talk a bit about that. And then also analyze some of the ethnic variations in colorectal cancer screening. So I'll start off with a case, and this is something that I want you to keep in mind while you're listening to the talk. So this is a very common presentation to our clinic, and these are some of the questions that I want you to think about when I'm presenting. So Mr. X is a 47-year-old Hispanic gentleman who presents to your clinic for a follow-up on his type 2 diabetes. And his care gaps show that colon cancer screening is required according to the American Cancer Society and the United States Preventive Service Task Force. So do you think that discussing colorectal cancer screening is important during this visit? And the second is, would you want to know any additional information about this patient? And third is, if you decide to choose a screening test, which one would it be? So just keep those three in your mind, because I'm going to come back to this case afterwards and ask you. So in terms of epidemiology of colorectal cancer, it's the second leading cause of cancer death in the United States and in the US and globally. So the lifetime risk is around like 4 to 5%. And I heard some people talking like it's rising and we're seeing it more and more even in 40-year-olds. So that's true. In the absence of screening, 7 to 8% of 40-year-olds would develop colorectal cancer, and about 3 to 4% would actually die from it. So the incidence rates are highest in developed countries, and that's probably due to our processed foods and sedentary lifestyles. But if you look at it from the 1990s, the incidence of colorectal cancer has actually decreased significantly. And this impact is mainly seen in those who are 55 and above. But if we look at the age groups who are younger than that, if you look here, it's trending downwards. But if you start looking at 50 and 54, 45, 49, 40, 44, 35, 39, 30, 34, 25, 29, it's all rising. So this was an indication that they saw, because before the screening guidelines said let's screen from the age of 50, but when we started seeing this, that kind of gave the clue that, hey, we need to start screening earlier. If you look on this side, you see that this is the white population in blue, and then the black population in gray. So obviously the incidence rate is higher in those 50 and younger in the black population compared to white. And in the bottom right here, you see that obviously men have a higher incidence than women. Either they're less than 50 or above 50. But then if you see the less than 50, the incidence is actually trending upwards, which is similar to what we see here. So it's both in male and females, not just in one gender. And then down here, you see 55 and above, the incidence is actually decreasing, but still more prevalent in males. So what are the risk factors? Again, age is a big risk factor. If you're 50 and older, male sex, African ancestry, family history or personal history of colorectal cancer, if you have inflammatory bowel disease, if you have obesity, diabetes, tobacco use, alcohol use. So all these comorbidities, it's very important to control for them when we see our patients. It doesn't just necessarily mean like we just screen it for colorectal cancer and that should be enough, but we should be effectively managing their comorbidities. Now, why, and this is the main reason why colorectal cancer incidence or prevalence is high in developed countries, because the consumption of red meats and processed foods, reduced intake of fiber, our vegetables and fruits, there's a lower intake in that as well. And then there's some bacteria and viruses that are involved in colorectal cancer as well. In terms of protective factors, get your exercise, eat your fiber, eat your fruits, eat your vegetables, and then there's some data showing that NSAIDs and supplementation of folic acid, calcium, and vitamin D also help reduce your risk for colorectal cancer. Obviously, the studies for those are not very robust, but there have been some studies showing some benefit. The pathophysiology, I'm not going to delve too much into this. That's not the purpose of this talk, but most colorectal cancer is sporadic. 90% of sporadic colorectal cancer is adenocarcinoma. And what I'm trying to highlight here is basically that it's a multi-step process, and there's three different mechanisms that you can develop adenocarcinoma. And the first one is the chromosomal instability. You have your genes APC, which is a tumor suppressor gene, and then you have your KRAS, which is an oncogene, and the P53 is also a tumor suppressor gene. So when you have a loss of function of APC early on, then you get a mutation of the KRAS, and then another loss of function of P53, you develop adenocarcinoma. And P53 happens later on in the course, and this accounts for 70% of your adenocarcinomas, and that's linked to your familial adenomatosis polyposis. Now, the second mechanism here is your microsatellite instability. It's related to the mismatch of repair genes, and that's linked to Lynch syndrome. And the third one is not that common, but is secondary to hypermethylation. Now, this is just another, I'm just trying to reinforce that it's a multi-step process. And you can see that there's a lot of steps that go from a normal epithelium to your invasive metastasis of colorectal cancer. So, updated screening guidelines, and that's the whole, reason why we're having this talk. So in 2018, the American Cancer Society actually made a qualified recommendation that we should start screening our individuals who are 45 and above, or the 45 to 49 age group. So the qualified recommendation basically means that there's some benefit. It's not an absolute recommendation, but they did start recommending it based on, your patients and their comorbidities and all that sort of stuff. So it was something to look at. But the United States Preventive Service Task Force did not recommend this in 2018 until May 2021, when they found that there was a moderate net benefit in those who are 45 to 49. Compared to 50 and 75, there's a substantial net benefit. So again, it's not an absolute, but they did see some benefit of screening in this population. And then you have your multi-service task force, so the American Gastroenterology Association, you have your American College of Gastroenterology, and then American Society of Gastrointestinal Endoscopy. They started also started screening at the age of 45. And again, going back to my point, why? Because 10% of colorectal cancers were being found in those who are 50 and younger. And in 2018, 31% of the eligible adults in the US were actually not up to date with colorectal cancer screening. So how do you screen for colorectal cancer? We have stool-based testing and we have visualization testing. So stool-based testing involves the FOBT, which we are all aware of, and then fecal immunochemical testing, and then you have your Cologuard, which basically uses the fecal immunochemical testing and combines it with the DNA markers from the tumor. And then with respect to the visualization, you have your colonoscopy, sigmoidoscopy, and the CT colonography. And the goal, again, is to detect the polyps or to detect cancer early on so that we can effectively manage it. So if someone can tell me, this is a picture of a colonoscopy actually, if someone can tell me what technique they're actually using here to remove this polyp, just, if you know, just scream it out. Snare. Right, snare. Yeah, there you go, Amaka. I knew you would get it. So again, if you look at your top left, this is the polyp right here they've identified. This is a snare. So the scope pulls out this snare right here around the polyp, and if you look at your bottom left, they kind of squeeze a snare around this polyp, and in the end, you have your polyp is removed, sent off for biopsy, and then you have some bleeding. They put a clip on it, and then that usually stops the bleeding. So good job, Amaka. Feather would be proud. So I just want to review some sensitivity and specificity before I talk about the different modalities. So sensitivity, what are we measuring here? The proportion of patients who have a disease should test positive, okay? So if you have the disease, you test positive. Specificity is a proportion of patients who do not have the disease and test negative. So screening typically revolves around sensitivity, highly sensitive tests. So remember, snout and spin. So snout for sensitivity. So if it's sensitive and you test negative, you can rule it out. If it's specific and you test positive, then you can rule it in. So just like rheumatoid arthritis, you have your anti-CCP and your rheumatoid factor level. So rheumatoid factor is not as specific as anti-CCP. So when your anti-CCP is positive, because it's a highly specific test for rheumatoid arthritis, you can rule it in. Thank you so much. You can rule it in, so spin. Now, stool-based testing, I'm just going to talk a little bit about the different tests and their sensitivities, just so that we have an understanding and why we use which and when. So you have your FOBT. This is a chemical reaction that is done with the stool, and the sensitivity is around like 60%. So not a very good test for checking for colorectal cancer. It needs a diet prep, so you have to be off of NSAIDs, because NSAIDs can actually cause you to have a GI bleed or a gastric bleed, and you can have a false positive. If you're on vitamin C, that interacts with the chemical reaction of FOBT, and you'll have a false negative. And then if you have, if you're eating a lot of red meat, the blood from the meat will actually cause a false positive. So you definitely need a diet prep. You need 3 different stool samples. It's a home test. It's not something you're supposed to do in the clinic or in the hospital. Then you have your fecal immunochemical testing here. Again, this uses antibodies to hemoglobin, so it's slightly more sensitive. You don't need any prep, so that's good. And the sensitivity actually goes up to 75 to 80%. I mean, it's between 70 to 80%. And you do this annually just like your FOBT. The Cologuard, which is an emerging option, it basically combines FAT and the DNA markers. And the sensitivity, if you look here, is 92. So the newer ones, and I was actually talking to one of the reps, Randy, for Cologuard, they have newer ones which are reaching about 95% sensitivity for the Cologuard, which is comparable to the colonoscopy. But again, this is an emerging option, but it's costly, especially for those who are uninsured, because it costs up to like $700, $750. So how did it work? Again, I'm not gonna go too much into it, but you smear your stool onto samples or tubes, send it to the lab. If they found any blood or DNA, then you need a follow-up colonoscopy. So just because you had a stool test and it comes back positive, you still need a visualization test. So visualization test has your colonoscopy, 95% sensitivity. You repeat it every 10 years if it comes back normal. And the point is to basically they visualize your whole colon. If there's any polyps, you get them removed. And depending on what the biopsy from those polyps showed, there'll be an interval colonoscopy done either at 10 years, 5 years, 3 years, or 1 year. Sigmoidoscopy is another option, but the problem with this one is it can only go so deep, and you miss lesions in the proximal colon, so it misses right-sided lesions. And the CT colonography, again, it has 90% sensitivity, not used very much. Some of the emerging methods, you have your blood test, especially for those patients who do not want a stool test or they don't want a colonoscopy, and I've met some of those kind of patients here in our resident clinic. So the blood test is an option for them. However, the sensitivity is only 83%, so it's similar to your FIT. It is FDA approved, but just know that this blood test is not recommended by the American Cancer Society for colorectal cancer screening. So I would only use this in those situations where your patient does not want the stool test or a visualization test, but you just want to screen them. You have your ColoSense. So similar to Cologuard, this Cologuard is for DNA, and the Sense is for RNA. So very similar, but again, this is not recommended for colorectal cancer screening yet because of lack of data. So this is some data from 1997 to 2014 about your blood test, and you saw that initially we did have some higher rates of usage, but then it has been trending downwards, especially in Georgia and the US. In the US, the usage is trending down more than Georgia itself. So again, this is a summary slide. The most common the modality for screening is your colonoscopy. Then you have your stool-based testing at 8.8%. Then you have your Cologuard, which went from 2.7% in 2018 to up to 8.3% in 2021. So again, it's an emerging option. And then a flexible sigmoidoscopy and a CT colonography are not really used that much. The only thing I want to point on this slide is if you look at your demographics in 2018, non-Hispanic white population, non-Hispanic black population, the usage of colonoscopy is 64.2 and 60% respectively. But if you look at your non-Hispanic Asians and Hispanics, that rate drops significantly. But the key thing here is, and this is where we come into like the social demographic issues, English-speaking Hispanics are more likely to choose than Spanish-speaking we're talking about colonoscopy here, and the rates rise with better access. So it's not that the Hispanic population does not want a colonoscopy. Sometimes because of language barriers and cost issues, they can't get a colonoscopy, or because of lack of care, access to care. So just know that, and this is one of the reasons why, it's important to use a language interpreter when we're talking to our patients in our clinic, so that they do have a better understanding of what we're telling them and why a colonoscopy might be a good option for them. Again, this slide, I just want to, because a lot of it comes down to cost, and we don't know the cost a lot of the times, and this is just an average. It's not, don't quote me on these numbers. So the total cost of colonoscopy, is $2,383 if you were not insured. And if you had, that's with a polyp removal. If without polyp removal, it's like $1,779. But out of pocket, if you can see, is $234, $267, and $46. So if you have a screening colonoscopy, and if you have insurance, usually you don't really pay anything, depending on what kind of coverage you have. But if they ended up removing a polyp or doing some sort of intervention during your colonoscopy, then you obviously have out-of-pocket costs. So it's not free. Stool-based testing, again, what I'm trying to say is it's effective, 15-33% reduction in colorectal cancer mortality. FIT is more sensitive than FOBT, and this is a choice of test for Hispanics and Asians because they're more likely to adhere to a home test. So these are home tests, so we prescribe them for them to be done at home, but what happens is you prescribe it, they get a kit, but it just sits there and nothing gets done. So the studies show the Hispanic population and the Asians are more likely to complete it than our white population. So again, these are very cheap tests. So if they don't have insurance, they're very good options. So if you look here, out-of-pocket cost for a FOBT is like $1 if you have insurance, and sometimes it's free, and then FIT is $8. So otherwise, it would be $21 and $6. And for a Cologuard, this is underselling it, saying $524, but this is probably because of the old Cologuard. With the newer Cologuard, they're going up to $750. But if you had insurance, then your out-of-pocket cost might only be $25. And we already talked about this. But again, it may be affordable for our Black, Hispanic, and Indigenous groups because of higher poverty rates. So, and I already talked about this, increasing use of Cologuard, but you see the colonoscopy makes up most of your screening. And if you look at your sigmoidoscopy, it's not really relevant anymore. So that brings me, before I move on to the trends and ethnic variations, I do want to mention a little bit about inpatient FOBT use. So like I mentioned, it's a home test. You have to have 3 different stool samples. You smear them onto your tests and send them to the lab. And you have to have a diet prep, okay? However, what we're doing here in the hospital is because of a GI bleed, we order FOBT, and if it comes back positive, we consult GI and they end up getting an endoscopy. So we looked at data from Northeast Georgia Medical Center from 2018 to 2021, and we saw that almost 3.1 million FOBTs were ordered during this period of time, and almost 11,000 tested positive. And from those who tested positive, 700 or so went for upper endoscopy, and 300 or so went for a colonoscopy. And 61% of those patients did not actually require such urgent evaluation or endoscopic evaluation. So we unnecessarily wasted resources and consulted GI, put a patient under anesthesia, did an endoscopy. So the point is, it's not a sensitive test, and we reduce its accuracy even more by doing it in the hospital. So we do 1 sample here in the hospital, and they're usually done in the ED, and you don't have any diet prep. So the accuracy that it had, you've lowered it significantly. So not an accurate test, not a sensitive test, not used for GI bleeding, is used for colorectal cancer screening, and is used in the outpatient setting. So we had done a QI project on this, but it was mainly done by, the workday module was mainly done by our residents, so it didn't really make much of an impact because the FOBT is usually done in the ED, and it's used for triage purposes. So if someone's coming with a low hemoglobin and complaining of GI bleed and you do an FOBT, then that gives them a reason for an admission. But that's not the reason. If it's a GI bleed, you should know it's more so clinical, and if their labs prove it, then you call GI, not because the FOBT is positive. So just please keep that in mind. At least as residents, we shouldn't be ordering it. Okay, so rate of colorectal cancer screening. The goal is set by the American Cancer Society is 80%. Are we meeting that goal? No, we're not. Nationally, in 2021, we were at 59% in 45 and above. In Georgia, we're at 64%. Does anyone want to take a guess where we're at in Hall County? Just yell out a number.
38.
We're actually much better than that. We're at 68.6%. This is estimated, so we're actually doing a good job, okay? But not a good job as much as we should be doing. So these just show, between 2014 and 2020, the rates have increased overall. But once you break them down between the different ethnicities, the non-Hispanic whites have higher rates. This blue is good, this is not good, right? So this is like 50 to 60%, and this is our Hispanic population. So they have improved from 2014 to 2020, but we're not doing as well as we should be. This is a very important chart I want to spend some time on, and I want you to understand. So this is from 2021 NHIS data. So in 2021, only 59% of the patients were up to date with their colorectal cancer screening. Now let's break that down. It was even between males and females. But if you look at the age group, the 20% of 45 to 49 were actually up to date. And it is very low, but I think the reason for that might be because the screening guidelines were changed in May 2021, so that's why you're seeing a lower number. And I'm sure if we were to repeat this study, that number would be higher. But the trend is as you age, the screening rates go up. Also interesting, in the 45 to 49 age group, only 18% people use colonoscopy and 3% use the stool test, but again, we weren't really screening them during this time. But as the age goes up, more and more patients want to use a colonoscopy. So younger population does not like invasive testing. That's what I'm trying to get at. If you look at your race or ethnicity, the type of test matters because only 46% of Hispanics were using a colonoscopy and up to 14% were using stool-based testing. But if you look at your white population, only 9% for stool and 57% for your colonoscopy. And the Hispanic population is very similar to Asian and the American Islander population. Immigration status is one thing that we need to keep an eye on. If you look at this number, I think it's pretty low, but if you're in the US fewer than 10 years, only 29% people were eligible were up to date with colorectal cancer screening. And only 25% of those were using a colonoscopy and 10% or 9% were using stool-based testing. So the time spent in the US is important. Either, I don't know if it's a cultural difference, it's a language barrier, it's a financial issue, it's multifaceted, and that's something that we need to keep in our mind. Education, as you get more education, your screening rates go up, your colonoscopy rates go up. If your income, same thing, finances, screening rates go up, your colonoscopy rates go up as well. And, you use less and less of your stool-based testing. Insurance, look at this. So 21% of people were up to date with colorectal cancer screening if they were uninsured. And 18% were using colonoscopies. But as soon as they get any type of insurance, that 21% goes into the 50s and 60s and 70s. So that just tells you that cost is one of the biggest issues we have for colorectal cancer screening. So summary, I wrote this summary slide mainly because I want to drive the point home. When we're seeing patients in our resident clinic, there are certain patients that we need to be paying closer attention to. So 45 and 49 age group, Asian Americans, individuals with less than a high school education, uninsured, and recent immigrants. So these are the populations you know that they will not get screened or they have a higher chance of not being up to date with their colorectal cancer screening, and we need to be spending more time with them, with more communication and education so that they are up to date. And also just note that only 18% of the 45 to 49 year age group is up to date is using colonoscopy, and you see the trend that with age, colonoscopy goes up. So when you're talking to a younger patient, you do not want to use, you want to give an option, but just know that if it's using a stool-based test, that's not a bad option. Now, this is a study, that was more national data. So I'm doing a study here at Northeast Georgia Medical Center about the ethnic variations in colon cancer screening, and we're looking at the data from September 2018 all the way up into 2023. We have about 47,496 patients, and we wanted to see what kind of modality they use when it comes to colorectal cancer screening. And the study is still in the analysis stage, so I don't really have all the data, but I just felt that it was relevant for this talk, so I just made some charts myself with the data, so forgive me. Now, the thing is that we did not include Cologuard in this. That's something that the data I'm going to request from these patients. It's only using stool-based testing, sigmoidoscopy, and a colonoscopy. But pre-May 2021, which is when the guidelines changed, we see that between Hispanic population and non-Hispanic population, the trend was very similar for stool-based testing and colonoscopy, although colonoscopy was a little bit higher in the non-Hispanic population. And we had like 17,000 patients, which is not that high because post-2021, we had much higher patients. But we know that this is a representative population because we have 7.6% Hispanics and 92.4% non-Hispanics. In Georgia alone, we have about 11.1% of Hispanic population, so it was somewhat representative. But if we look at post-May 2021, this is when you see the real changes. And just know that in 2020, late 2020 and in 2021, we had COVID. So that's why the colonoscopy rates were lower and the FOBT rates were actually, or FIT rates were higher in the non-Hispanic population. But as soon as we come post-May 2021, we have about 30,480 patients, 8.2% are Hispanics and 92% are non-Hispanic. And you see that the stool-based testing reduced significantly in the non-Hispanic population, and the colonoscopy went up to 85.1%, which is impressive because when we were looking at the NHS data from 2021, colonoscopy was around like 60-61% nationally. So I'll talk, and then if you look at your stool-based testing for your Hispanic population, again, it makes almost about 30% of their testing. And then, but the colonoscopy rates, again, 68.5, which is very high. So this tells us about the uptake of colorectal cancer screening modalities among our populations. And obviously, when we get the study back, we'll break down the non-Hispanic between whites and blacks, and then we'll also get if there's rural or non-rural populations. So we will have more data. But right now, it also tells us a lot about our prescribing patterns. It seems like, at least us from this data, we're relying heavily on our endoscopic evaluation for colorectal cancer screening, and we might be underutilizing our stool-based testing, which is actually pretty good, and I'll come back to that in a bit. But again, these graphs drive home the point, non-Hispanics, a lot of colonoscopy after 2021, and the stool-based testing went down. In the Hispanic population, again, stool-based testing was a significant portion of their testing before 2021 and after 2021, but colonoscopy did go up again because, maybe most likely because of the COVID pandemic. So what are the barriers to colorectal cancer screening? We're not at the goal of 80% and we need to get there. How do we get there? Well, some of the barriers that I found personally and looked at online are healthcare access and quality. You have your level of education, language proficiency, economic stability, and social and community context. And I'm not going to go into these studies individually, but just know that some of the strategies to achieve these colorectal cancer screenings that I saw online that were effective and have been repeated multiple times include like these mail-to-home FIT kits and text messages, so reminders. So they increased colorectal cancer screening by 17.3% in a Black community. And then using telehealth was effective as well, but telehealth was not as effective in some groups because they were not using these, obviously because of financial reasons. And then culturally relevant education also and print material is important because it increased colorectal cancer screening completion at 6 months by 40% in mainly a Hispanic population. So making sure we're doing culturally relevant education, that's very important for them to actually accept your test and complete it. So reducing, eliminating cost sharing. Cost sharing basically means that you got screening tests done, you should have no out-of-pocket costs. And especially if you did a stool-based study and then you're gonna go for a screening colonoscopy, there should be no out-of-pocket costs, but unfortunately, it's depending on which insurance you have, there will be out-of-pocket costs, and some people can't afford those, so they do not go ahead with their subsequent colonoscopy. And again, providing culturally-based community. So some people did colorectal cancer screening education in the churches and they found that that was effective. Now, these are recent studies, so I want to spend some time on them, but I won't go too much into each study, but these are published in Lancet, both of them, and very close to each other. This one was in March 29, 2025, and this one was April 12, 2025. So that this one will talk about the behavioral interventions to increase uptake of FIT. So again, they want to see how can we improve patients to complete their stool-based testing, specifically the FIT. And this was an 8-arm study, it was a randomized controlled trial, and what they did was they had patients who just were prescribed the FIT test and they had to go home and do it with no deadline. Then they had other groups who had a 1-week deadline, 2-week deadline, 4-week deadline. And then there was another group who actually had basically a sheet which showed them, hey, what issues are you having with completing this study? And then it gave them some solutions to their issue. So, and then along with that they also gave deadlines. So 8-arm study. They found that patients completed the FIT more when they had a deadline and that navigation sheet, especially a deadline of 2 weeks. Now, I'm not gonna, fool you. The effect was not that large. It went from about, I think, it was about 62% to 64% of completion rate at 2-week deadline. But what this tells you is that just a small behavioral intervention, such as a reminder or a deadline, will increase your completion rates. And it's similar to this talk. I was supposed to do this grand rounds a long time ago. I completed it near the end. So deadlines do help because all my engines were firing near the end as well. So if we can start incorporating this into our clinics, calling them and setting a deadline, it may help. Now, then this is a very important study here. It was published in 2025, April 12th. And it had about like 50,000 patients involved in it. and they randomized patients to getting an FIT test or a colonoscopy. And they found that the completion rate of a colonoscopy was 33%, whereas the FIT was about 39%. And the FIT was actually non-inferior to the colonoscopy when it came to the 10-year mortality from colorectal cancer. So what does that tell me? FIT is very effective, it's useful, it's non-inferior in terms of mortality, and it's cheap. So definitely use FIT when it comes to those patients who can't get a colonoscopy due to cost issue, preference issues. It's sensitive, it's 80%. It's not perfect, but it will do the job. And when we associate it with some behavioral interventions such as reminders, we'll actually get higher completion rates in our clinic. So again, we're talking about our clinic, so how do we increase the rates? Well, March was our colorectal cancer screening month, and in our resident clinic, I didn't necessarily see any posters or any print education about colorectal cancer screening to raise awareness amongst our patients. So if we can increase print or electronic education material, patients will be more aware, it'll be easier to talk about them, and for the whole month, they'll be exposed to this information that they can digest, and then maybe if we had pamphlets they can take home, read, so that by the time they come back to us, they're more primed, they know the options, and they're able to make more of an informed decision. Again, it's important to have a brief discussion with them during our office visit. It's important to educate them. If you told my mom and she came to the clinic, she doesn't even understand English, and you told her to do colorectal cancer screening, and especially a colonoscopy, she wouldn't do it, okay? She wouldn't even do a stool-based test because she doesn't know, and she doesn't even know why she should do it. Offering patients a choice between different modalities. So this is very important. I read a lot of studies or multiple studies saying that when you gave patients an option between the different modalities, they were more likely to choose one of them. It doesn't necessarily mean they'll choose colonoscopy or a stool-based test, but there was an increased chance of them accepting a modality and actually completing it. So definitely give them an option, and offer stool-based testing, especially fecal immunochemical testing for those who are insured, because it works, okay? And the telephonic reminders, like I talked about, if we can set a deadline or remind them, just like we started doing for the blood pressure. So our MAs called them within 24 hours to see what their blood pressure at home was. So that's a good measure to see if their blood pressure is actually high or not, instead of just saying that they're hypertensive. So similarly here, if we prescribe a stool-based test, then we should follow up with them to make sure that it does get completed. Not just that. If they had a positive stool-based test, then they need an endoscopic evaluation, and we need to make sure that they go and get their colonoscopy done. The longer they wait, the data shows the longer you wait, the more chances of you having an advanced adenocarcinoma at the time of diagnosis. So poor outcomes for those individuals. So make sure that we reach out to these kind of patients. They're at high risk. So making sure that they do get their colonoscopy. And using a language interpreter when in doubt. So, a lot of times if they speak some English and we're in a rush, we may not use a language interpreter, and I'm guilty of that. So we should definitely use a language interpreter when we're in doubt that they're not understanding what we're saying. And being able to identify, so this is for us, being able to identify patients at high risk for colorectal cancer based off their comorbidities, family history, personal history. And also, the data I showed you, patients or populations who have low local and national screening rates. So those are our high-risk populations, and we need to make sure that we accurately identify them and spend more time with them for our colorectal cancer screening. So, and this is something that we're always confused about, and I'm always confused about, but we as doctors should know this, because what is a high-quality colonoscopy? First of all, we should know that, and when we're reading the colonoscopy note, we should be looking for all of this stuff. Now, depending on what they find in the colonoscopy and the biopsy results, that determines when their repeat colonoscopy will be. Will it be in 10 years? Will it be in 5 years? Will it be in 3 years? Will it be in 1 year, right? Because if you have a high amount of serrated polyps, well, it's not going to be 10 years, and it might not even be 5 years. It might be 1 year, right? So knowing this chart really helps, because what happens is that studies have shown that patients have actually been getting post-colonoscopy colorectal cancer. So how is that possible? They had a colonoscopy. Why do they have colorectal cancer? Why didn't you catch it, right? So 2 to 8% of colorectal cancer is coming from post-colonoscopy. And they found that a lot of the lesions or the cancer came from previous sites where they found polyps. And either, you didn't completely remove the polyp, or because we did not technically follow up at the designated interval time with a colonoscopy. So make sure that we know this. This also comes on the board as well, depending on how many polyps or findings they find in the colonoscopy. So again, so we come back to the case. So this guy, he comes here, he's Hispanic, and he's coming for type 2 diabetes. So his care gaps show that he needs cancer screening. What are you guys gonna do?
What do you think we should do? Who can answer? You want to answer?
I think Henry wants to, yeah.
I would say make sure you have an interpreter with you and recommend different modalities for colon cancer screening.
He's
That's a good catch.
Good catch, Amaka. We don't need him, I can hear you guys, or I think they need it for online maybe, yeah.
I mean, I would definitely discuss screening with him. He's age appropriate, and then we know that Hispanics in general have higher rates of colorectal cancer, mostly because they're not being screened. Yeah, I mean, I'd want to know
Would you want
any
to know
additional
any more information
maybe
from
any
here?
symptoms that he's having, maybe family history, things like that.
Yeah, and I talked about it previously, cost is a big issue. So does this guy even have insurance?
Yeah.
Right? Because depending on insurance status, we will determine which one we're gonna offer him. We're gonna offer him options, but we want to know if he has insurance, and then level of education is important, family history, personal history, comorbidities, and all that sort of stuff. So, but for me, main thing is cost issue and then the level of education, and if they can speak English or not. I think those are really, really important. So, Amaka, if I told you this person is uninsured, they can speak English, and they're from Hall County, which test would you give them?
I would say FIT has a high sensitivity rate and it's low cost.
Right. And if he was insured, what would you offer him?
Colonoscopy, higher sensitivity and specificity.
Right. So, yeah, so colonoscopy is a gold standard, but obviously giving him options. So, like I said, if we give him options, they're more likely to uptake it, right? Because maybe this person, culturally, they don't do colonoscopies. Who knows, right? So if you say, hey, there's a stool test, Cologuard, you're insured, it has almost 95% sensitivity. So they might be more likely to uptake that Cologuard instead of the colonoscopy, and it's a 3-year interval if it comes back normal. So I agree with you. Those are right. And then in conclusion, all I want to say is just know that there's different modalities and there's a place for each modality, and know your patient preferences and their demographics. But the best screening test is the one that gets completed. So our goal is to make sure that test gets completed, okay? And recognize the increasing role of FIT and Cologuard in colorectal cancer screening. That's very important. We don't always have to do a colonoscopy. And please follow up on a positive stool-based test for a visualization test, such as a colonoscopy, because otherwise we're just sitting on something and they're gonna have an advanced cancer at the time of diagnosis. And do not order FOBT in the inpatient setting, please. And this is a completion of my talk, but again, I want to thank Dr. Gross because he's a real MVP. He's always there when we need him. I sent him these slides last minute, and he made sure that he gave me valuable feedback, and I really appreciate him. So thank you so much, Dr. Gross.
Thank you, Dr. Akhtar. If you're viewing online and have a question, please enter it into the Q&A section, and we'll make sure to ask that for you. We do have a question in the audience.
Sure.
Great job, Adil. It's not a question, just a plug, really. So myself and Rahul are actually doing a QI project on this exact thing in our resident clinics. I created a poster, there's actually 2 of them, in regards to educating patients about the screening modalities and any symptoms and should they be screened at all. So that will be in the patient rooms, hopefully May 1st. Just need to talk to Tina. So it should be in our resident clinic here in Gainesville, the one in Brazelton, and then we're speaking with family medicine to have it in their clinic as well.
Yeah, that'd be great. And for us too, in our resident room, because especially for some of us who are starting off, we don't necessarily know what an FOBT or FIT or Cologuard is. We just know what their names. So it would be helpful for us as a reminder if we forget.
Great suggestion. Any other questions or comments? Oh, okay, hold on.
Thank you, Adil. That was a great presentation. I'm kind of curious because nowadays we see a lot of younger people in their 20s, 30s getting colorectal cancer, and they don't really have any family history. So what do you think in the next 5 to 10 years, do you think guidelines are going to change to get screening age lower? Or how do you think we should approach these situations?
Yeah, I think that's a great question, and I'm sure that they postulated your question when they were making that recommendation in May 2021 as well, because there is an increasing incidence of colorectal cancer in the younger population, especially below 50. The reason that they made the change from 45 and 49 was mainly because that's where they found that there was a moderate net benefit. There's not enough data out there to suggest that screening in those 40 and younger would actually prove a net benefit compared to the risks. And I think it's very important that the studies are still coming out. So when we publish this Northeast Georgia study and other places start publishing their studies about which modalities we're using and if colorectal cancer screening rates are going up and if we're finding them more and more in this 45 to 49 age group, once we have data from that, I think then we can postulate if lowering that screening age will actually be more effective or not.
Just a small piggyback on that. There's obvious cost difference between the FIT DNA versus colonoscopy. I mean, would you see them lowering guideline age to incorporate FIT DNA in our younger populations, as opposed to could you see it being like in your 20s, do FIT DNA while colonoscopy still stays as the gold standard for 45 and up?
My question to you is why? So are you saying that there is a net benefit, but we're not screening these younger patients because of cost?
Yeah, no, it's just more of a postulation, kind of as Dr. Kalra mentioned, the lethality in the younger populations that you're seeing. Would there be a cost benefit? I don't know. It's just more
so
like
I think I'm not sure if it's related to cost itself. I think when we look at if we should start screening at a lower age, it's more so mortality benefit, right? So because if there was a mortality benefit, then these insurance companies would be more inclined to actually, and we'd be pushing them to cover these tests, right? But if you're looking at the 20-year-olds or 30-year-olds and getting cancer, a lot of it is genetics, right? And sporadic adenocarcinoma, the incidence goes up with age. So I'm not sure if cost is an issue there, and I'm not sure if Cologuard will lower that screening age, or the screening age would be lower just because Cologuard is cheaper. I think they're going to stick to the 45 to 49 for now and then go from there.
And then just a second question. Do you see guidelines changing at all to incorporate AI within the colonoscopies? Is that something you came across at all, or?
So I think those are two separate questions. When we look at AI in colonoscopy, that's mainly for your adenoma detection rate. And there's a study that we did actually here at Northeast Georgia Medical Center, especially with lowering the screening age from 50 to 45. We wanted to know what the adenoma detection rate is. And for those who don't know, adenoma detection rate is how many polyps, or on average, what is your detection rate of polyps for that age group? And we saw that the adenoma detection rate was similar for those 50 and above, and between those were 45 and 49. So the adenoma detection rate is very similar for both groups. I think that AI may help increase that adenoma detection rate. I'm not really sure if it would change anything about screening. But, to your point, maybe if we're detecting more and more adenomas with AI, we'll see that maybe it goes lower to 40 because we see those precancerous lesions earlier on, so possibly.
Great presentation, Dr. Akhtar. I just had one question. You put up a slide about your study. I realize it's very preliminary.
Very primitive.
Very, very preliminary, but I was just curious because I would have thought in COVID that the home testing or FIT test or Cologuard would have increased due to lack of exposure to COVID and things like that, having to go to the endoscopy suite, intubation. Yep. But the colonoscopies went up. So why do you think that is?
So that's a good question.
Especially with financial strain during COVID-19 with the at-risk populations that are not perhaps getting screened as much,
Yeah.
What are your
so
thoughts?
I'm still requesting the Cologuard data, so this doesn't actually include Cologuard. So if you look at it, this is mainly FOBT and FIT and sigmoidoscopy and colonoscopy, so there's no Cologuard here. But if you look here, pre-2021, which is during the COVID time, FOBT for the non-Hispanic populations, which normally prefer colonoscopy, was pretty high, right? And that drives your point that they were not doing the colonoscopies as much, right? We weren't prescribing them. What happens after? it goes down significantly, 6.8% and 6.5%. So stool-based testing did drop significantly after, and we started doing colonoscopies again. But this trend, but it did not change much for the Hispanic population, and there's a reason for that because of cost, all these different things that I mentioned in my talk. But it also talks about our prescribing patterns here at Northeast Georgia Medical Center. Like, are we relying too much on colonoscopies and maybe missing patients who could be screened? And maybe that's some area where we can actually improve our colorectal cancer screening rates by introducing those fecal immunochemical testing or Cologuard. But like to your point, if you see at the beginning of my talk, I talked a little bit about the increasing rate of Cologuard. In 2021, you see it goes up, right? And I suspect that to continue going up because it's highly sensitive. And as we get more and more coverage for it and it's lower out-of-pocket costs, it'll become a strong tool.
Okay, great talk. I think that the use of FITS, encouraging informed consent and sharing the different modalities, is wonderful. For instance, with colonoscopy, I think that overlooked factor in low of screening access is the need to have someone to be at the procedure during the full-time period. Many patients have trouble finding a friend or family member that can take the time off to be there with the patient. And that's from Dr. Helen Ransom.
Yep, and I completely agree. I actually had a patient 2 weeks ago, and I prescribed Cologuard mainly because I looked at the chart. This was the first time I had seen this patient, and they needed colorectal cancer screening, and they had done a Cologuard in the past. And in the overview under colorectal cancer screening, it says transportation issues. And this was a Hispanic patient, but spoke English, had insurance and everything. Mm-hmm. So I spoke to him and I said, like, hey, why not colonoscopy? And he basically said, well, I don't have anyone to drive me home after the colonoscopy. So that's a great point. It doesn't necessarily mean that they can't afford it or anything. Sometimes it's a transportation issue where they don't have the help that they need for post-care after colonoscopy. So good point.
Great. All right. Thank you, Dr. Akhtar.
Thank you.